one thing I've shifted to recently for my RF PVIs, which I have to say has changed my life, is single transeptal.
Oh, let's talk more about that.
Yeah, we'll talk
Euro
on
style.
Yeah, it's I just think of all the SL1 sheaths I wasted over the years. But yeah, it's not like me. I'm usually put more catheters in, map every chamber. But yeah, I was nudged into it by a trusted colleague, and I haven't looked back.
Yeah, definitely some merits to that. Kelly, do I need to do anything?
You can start your introduction.
Oh, people can hear me?
Yep.
Okay. Hi, Rob. Well, good morning, everybody, and welcome to Cardiology Grand Rounds. It's my distinct pleasure this morning to introduce Dr. Babak Nazer as our speaker. Babak is currently Associate Professor of Medicine at the Oregon Health Science University, where he directs a highly successful and academic multidisciplinary ventricular arrhythmia program. Babak actually grew up in the Seattle Bellevue area, and his extended family still lives here. He studied biomedical engineering as an undergraduate at Johns Hopkins, and then later went to Harvard Medical School. He completed his cardiology training and electrophysiology training at the University of California in San Francisco. His clinical interests focus on ventricular arrhythmia management, and his research interests also overlap with that, and they're focused on the use of therapeutic ultrasound. And he's applied that for treatment of VT, as we will hear him speak about that very shortly, as well as other applications, such as in treatment of patients with hypertrophic cardiomyopathy and peripheral vascular disease. So we're very excited to welcome Babak today, who is also an avid cyclist and woke up very early to bike across the bridge and make it to Grand Rounds. So join me in welcoming Babak, and thank you for attending this morning.
Thanks, Nazem, for the great intro and the invitation. Thanks also to Dr. McClellan for inviting me to visit, and to Lori for arranging my visit with everyone who's taken the time to meet with me. So I had the fortune to present to the EP group a few months ago on my work, and specifically focused on VT, and I'd like to broaden that to the broader cardiovascular applications of peripheral arterial disease and HCM. Here are my conflicts. But before we get into my work, I want to review the history of ultrasound. Most on a cardiology grand rounds audience are familiar with ultrasound as a diagnostic modality, and the echo folks are familiar with the history of it. Edler and Hertz first described the use of cardiac ultrasound for diagnosis in 1954. Originally using A-mode ultrasound. This is a short axis section of a heart. And on this ultrasound recording, at each tissue interface is a reflection of an ultrasound wave. This is A-mode ultrasound, which we no longer really use today. That rapidly moved to M-mode ultrasound in a subsequent publication by the same group, which we are familiar with using today. But what people don't know is that the use of ultrasound for therapy, frankly, to destroy tissue, preceded that of its diagnostic use by about 17 years. In 1942, John Lynn first showed the ability of high-intensity ultrasound to destroy tissue via thermal mechanism. This is excised bovine liver studies that he did. And interestingly, on the far right, he showed a unique characteristic of ultrasound as an energy modality. Its ability to spare, these ablations were done from the bottom up, its ability to spare the tissue that it's immediately adjacent to, but still deposit the thermal energy and make the lesion deep within the tissue. That progressed over the years. 1959, the Fry brothers used this as a proof of principle in large animal models for the treatment of Parkinson's disease. largely the development over the subsequent decades was in the solid tumor space, as you might imagine. The first FDA approval for a therapeutic ultrasound thermal device was a company called Inside Tech. And that's an MRI-guided high-intensity focused ultrasound therapy for uterine fibroids. So the MRI allows alignment of the ultrasound transducers, which are focused, thereby focused on the uterine fibroid for non-invasive treatment of those. 2014, first in human treatment of a brain tumor was described with transcranial focused ultrasound. The most noteworthy publication in this field is in the treatment of essential tremor, which has achieved FDA approval as well. And then Parkinson's disease was also granted FDA approval as an indication for transcranial therapeutic ultrasound. I had the fortune of meeting with Dr. Elias on a trip to UVA, which is where this study was done recently. So I want to propose a taxonomy for therapeutic ultrasound that we can take forward for the rest of this talk. Obviously, there's a diagnostic arm, but we'll focus on the therapeutic arm. And you can think of the two different branches of ultrasound therapy in the thermal mechanism and then sort of a basket of non-thermal mechanisms. Now, the thermal mechanisms are usually imparted when the ultrasound's operated in continuous wave. So the transducer or transducers are always sonicating. They're on 100% of the time, what we call a duty cycle of 100%. And as I mentioned, FDA approval for uterine fibroids, essential tremor, and Parkinson's disease, a lot of work in the solid tumor and treatment of metastases space. And then cardiac ablation is what I'm going to get into. Now, in non-thermal applications, the ultrasound is usually operated in pulsed mode. So the duty cycle, the percentage of time that the transducers are sonicating is usually well under 1%, depending on the application. There's FDA approval for thrombolysis for this indication, a company called ECOS, founded in Seattle, which is frankly an therapeutic ultrasound and diagnostic ultrasound hotbed. And that company has recently been acquired by Boston Scientific. Drug delivery, peripheral arterial disease, which is what I'll speak about, where I have done some work in this space. And then immune modulation, interestingly, there's some exciting work coming out of Minnesota on sonication of the spleen for immune modulation for rheumatoid arthritis and frankly also COVID therapy. But let's start staying in this non-thermal path with peripheral arterial disease. Now, those of you who don't know me in the audience may be asking, what is an electrophysiologist doing talking about, let alone thinking about peripheral arterial disease? And I'll respond to that with the fact that I got my therapeutic ultrasound start well before I became an electrophysiologist. You should all know that you are working at one of the world's premier therapeutic ultrasound institutions. UW Center for Industrial Medical Ultrasound, which is part of the Applied Physics Laboratory and associated with biomedical engineering, is where I got my start. On summers home from college, Larry Crum, who's the director, Tom Matulu, who's the director, and Larry Crum, who's the founder of CIMU, were generous enough, along with other colleagues, to give me my earliest research experiences as a summer between high school and college, and then summers home subsequently. And we've kept in touch and become great friends and collaborators since then. Back then, a lot of the work in this space was in solid tumors, as you may imagine, for the thermal applications. As I progressed through my education and medical training, I started to get exposed to all of these sports medicine devices. I rode crew in college. I injured myself one year. I went to the NCAA physical therapy people, and they put ultrasound on my ankle. I said, well, what are you doing? Are you imaging my ankle? And they said, no. I said, well, are you burning my ankle? Because I used to do research in that. Like, no, we're not burning your ankle. And we're improving your tendon and muscle healing. And the sports medicine field has gotten away with this for quite some time without much data to back them up. These are usually direct to consumer devices. Sometimes they're marketed to physical therapists. And that really planted a seed in my head back then as I was progressing through, at this point through my cardiology training, about using this for initially myocardial recovery. Interestingly, there have been people thinking about this around that same time. So shockwave therapy, the same shockwave used for kidney stone lithotripsy, is a type of acoustic therapy, actually. It's just one single one single pressure wave instead of a series of sinusoidal pressure waves, which is what ultrasound is. And there have been multiple companies that have created devices using shockwave to promote myocardial healing for non-revascularizable CAD patients. Here's an example of one of such devices. These devices haven't taken off while they're CE mark approved in Japan. They haven't taken off clinically because they require 3 times a week therapy through an intercostal space, positioned by a sonographer, targeted to the area of ischemia. And so it's become quite a cumbersome clinical therapy to provide to patients, and requires in-person therapy. So guided by my mentors, Tom and Larry, they said, listen, why don't you move from an organ that's moving in between ribs and with lung in the way to an organ that is in that is a better acoustic target, frankly. And so we shifted my efforts during my postdoc from CAD in the heart to PAD in the lower extremities. With Tom's help, we developed a transducer that was frankly simulated to be similar in as many acoustic parameters to the shockwave therapy devices that had demonstrated some efficacy. My first of 2 postdoc projects was this. I generated a femoral artery excision peripheral arterial disease model in a rat. And then we sonicated the area of excision. We would cut out the femoral artery, all of its branches. It takes quite a bit of excision to generate an ischemic mouse or rat. And then we would provide therapy both along the area of excision and to the distal target muscle, which was the gastrocnemius. And we compared ultrasound, shockwave, and then a group of sham rats that were just given anesthesia. Here's the here's the model itself. So we used multiple endpoints, but laser Doppler was the best endpoint for demonstrating the ischemia to begin with. So here's the rat's tail down the middle. This is the normal paw, demonstrating normal perfusion with the brighter colors. And then here's the ischemic paw. So immediately after femoral artery excision, the perfusion to the ischemic paw is 42% of the normal control hind limb. And we treated these rats for 2 weeks, 3 times a week, with both ultrasound and shockwave improving perfusion by about 20%. By about 20%, with some non-significant improvements of ultrasound over shockwave therapy. You know, as an ambitious postdoc, I said, I'm gonna not only show the effect, but I'm gonna define the mechanism. In a 1-year postdoc period, that was biting off more than I could chew. But we did show that we increased tissue levels of VEGF. You know, VEGF is not a mechanism. Frankly, it's a marker, if anything. But we were able to show that. And concurrently with us, a Japanese group was looking at a rabbit model of PAD, and they showed the same thing with tissue VEGF levels, both mRNA and protein, I should say. Both of our groups looked at microvascular density in the target muscle with immunohistochemistry, labeling capillaries as is shown here, and we showed increased capillary density with ultrasound. And then in the rabbit model, this wasn't feasible in a rat model, the Japanese group showed improved collateral agenesis. So what you see here is the femur of the rabbit. The hip is on our left, the knee is on our right. The femoral artery would be coursing horizontally parallel to the femur. It's been excised in both of these. And you can see in the sham group, there are some collaterals that are recruited as naturally occurs. And in therapeutic ultrasound, the collateral agenesis is a much greater extent. And in the interest of time, I'm not going to show this data, but multiple groups have shown similar effects in coronary artery disease models in swine, both acute and chronic MI models. And as I mentioned, the shockwave therapy is used clinically in some countries. Now, after differentiating to electrophysiology and then joining the faculty at OHSU, I frankly was fortunate and that coincidentally, some of my new colleagues were interested in the same phenomenon. And I was able to continue this work, at least peripherally. My K08 mentor of my my K grant, Jonathan Lindner, and I work on this, and his lab has done a lot of work in defining the molecular mechanism, which is one of the things I'd hoped that I could contribute to. And our group at OHSU uses different endpoints than laser Doppler, although we're getting into laser Doppler. We use ultrasound microbubble perfusion. So the similar, sometimes the same microbubbles that you're used to giving to identify the lumen in diagnostic echo can be used with special imaging modalities to assess both myocardial and skeletal muscle perfusion. So shown here in the upper right, this is a mouse model of peripheral arterial disease. And using this method, we showed that there's not only a chronic effect of improving perfusion, but while the ultrasound is on, there's acute vasodilation of all arteries and arterioles in the field. And so this color scale you see here is a time course of the microbubbles perfusing the gastrocnemius. And on the top is a control mouse, simply on getting imaging, diagnostic echo. On the bottom is the therapeutic ultrasound mice and showing increased microbubble perfusion to the skeletal muscle. Here, the time intensity curves up here. And this has also been shown in humans. So on the bottom, one of my colleagues in our group is a pediatric hematologist interested in sickle cell disease. And so she recruited a cohort of sickle cell patients who are known to have vascular dysfunction. And in a very similar approach, using ultrasound microbubble perfusion, we showed improved time-dependent perfusion of their forearm muscles with therapeutic ultrasound. We've also shown similar data in peripheral arterial disease patients recruited from our VA population. I'd have to dedicate a whole hour of grand rounds taking you through how the molecular mechanism was elucidated. And I can share the references with those of you who are interested. But I want to boil it down to two molecular mediators of this. You know, when I was presenting this work 5 years ago, I wouldn't have a great answer when people would say, well, how does it work? You know, we believe you that there's an effect, but we want to know what is the ultrasound wave interacting with. And largely due to Jonathan's work, two mediators have been identified. So pannexin is a known mechanoreceptor. It's a shear responsive mechanoreceptor. And ultrasound does impart shear force on endothelium. So with a series of pannexin knockout mouse studies, we've been able to show that pannexin is partially responsible for this effect. And pannexin is known, even prior to its role in ultrasound, to increase endothelial nitric oxide synthase, which is at least a potent acute vasodilator, and may have some chronic effects mediating what I've shown you. The other molecular mechanism is direct ATP release. And red blood cells, I didn't know this until we started to explore this ATP route, are packed with ATP, as are endothelial cells. And sonication at the right dose, subthermal, but supradiagnostic doses, increases cell permeability. And one of the first things to leak out of cells is ATP. And as adenosine, you know, is used for FFR testing in the cath lab, as it is an adenosine analog, ATP is a potent vasodilator, and it's very well described mechanisms also lead to vasodilation through endothelial nitric oxide synthase and other pathways. So these mechanisms are definitely leading to the acute effect and likely also leading to the chronic angiogenesis effect that I showed in the gastrocnemius and collateral vessel formation that has been demonstrated. So what do I think the clinical application is here? You know, this isn't something that I live and breathe clinically on a daily basis, but it is a disease process that I'm passionate about contributing to improve, and that's late stage peripheral arterial disease. So PAD is a huge problem, 18 million total PAD population in the US, 200 million worldwide. If you look at exclusively symptomatic individuals, it's likely around 6 million for claudicants. You know, claudicants are certainly an unmet need, but CLI, critical limb ischemia, is the big unmet need. And our vascular colleagues in the audience can likely attest, this is the group that has very few therapies that work. It's a 2 million, a prevalence of 2 million in the US, and their outcomes are poor. Within 1 year of diagnosis, over a quarter of them have had amputations due to their CLI. Only a quarter of them CLI is resolved due to inadequate therapy. And in my collaboration with my vascular surgery, interventional radiology, interventional cardiology colleagues, I've sort of learned where the pain point is here. My electrophysiologist breakdown of the CLI is a 2x2 grid, is the way I think about it. And the disease really breaks down in my head to being above the knee disease, which is fairly amenable to both surgical and percutaneous therapies. But then below the knee disease, where the vessels are too small for anastomosis, stents seem to restenose, drug-coated balloons have shown some promise, but also some association with increased mortality, and recurrence rates are high, right? Even if you're below the knee and have fairly focal disease. Now, diffuse disease, is too long to stent or balloon, and especially when below the knee, essentially has no therapy. And that's the feedback I've gotten. So in my mind, this is the area where therapeutic ultrasound is poised to make a difference, below the knee diffuse peripheral arterial disease, and then subsequently expand to more focal below the knee disease and maybe more diffuse above the knee disease. But that part requires certainly more work. So my work in this field is actually being translated by a company that I've been fortunate to be involved with called Vibrato Medical, which is in its first in human studies presently, and I'd be excited to share more with you at a future date. But more importantly, where I think my career is going, as I'm not a peripheral arterial disease specialist, is to investigate other applications of non-thermal ultrasound modalities, and a few that are a little bit more relevant to EP, and a few that have come up during my conversations with a few of you yesterday. I'm interested in how some of our mechanisms may modulate progression of myocardial fibrosis. I'm interested in this in HCM model. I'm interested in this in just an aging model, hypertensive model, and diastolic heart failure models. This will probably be something we take on in small animals at first. Egress of amyloid plaques. This one's a little bit more high risk, high reward. I can't say I have a ton of preliminary data to say that we can break apart amyloid plaques, but there's certainly a lot of excitement with tafamidis and other TTR stabilizers and even some TTR silencers at reducing the future deposition of transthyretin in cardiac amyloidosis. What the current therapies are not doing great is breaking apart the plaques that have already deposited in the heart. And many patients at the time of diagnosis have already had a significant amount of plaque deposition. And I'm interested in doing some animal work and seeing how we can potentially modulate egress of these plaques with certain types of ultrasound waveforms. And then Kenza and I had a great conversation yesterday about stem cell engraftment, which is something that ultrasound could help modulate in multiple ways. All right, so back to my wheelhouse of VT. That's certainly my clinical love. So as getting back to my career development, as I differentiated from my cardiology research postdoc into electrophysiology fellowship, my subsequent mentors helped to sort of, shift my efforts to where we felt the unmet needs were in EP for therapeutic ultrasound. And I moved back, getting back to our taxonomy, to the thermal mechanisms. But let's take a step back and talk about the pathophysiology of scar-based VT. Not really well described until the late 80s. These are the initial studies sort of confirming that the mechanism of most scar-based ventricular tachycardia is reentry. And what is reentry? So this is a human explant heart, endocardial to epicardial section taken here, and microelectrode recordings are done of electroconduction through this explant, demonstrating very slow, we think of that and when we see these long fractionated electrograms, very slow conduction through heterogeneous tissue, right? So VT relies on heterogeneity. It relies on dense scar, so these gray patches, with persistently conducting, albeit slowly, viable tissue between them. And that work a few years later was subsequently demonstrated through a combination of computer simulations and human EP study recordings to mediate reentry. So large loops of conduction utilizing these slow, persistently conducting isthmuses, as we call them in the EP lab, which can be demonstrated through multiple ways and then targeted for ablation. But what are the challenges? Well, in the ischemic cardiomyopathy population, the scar and thus those isthmuses are usually subendocardial. And most often we can get to them through a endocardial approach, either transeptal or retrograde. Now, in non-ischemic cardiomyopathy, the scar can be wherever the disease process wants to put it. It can be epicardial, and unfortunately often is. It can be mid-myocardial, which is the most unfortunate situation in our world. And even some ischemics end up with a fair bit of their substrate on the epicardial surface, especially if they had transmural infarcts. Now, at institutions like UW and OHSU, we have no problem getting epicardial. It's not much of a challenge unless the patients had prior cardiac surgery. And so that's a group that unfortunately we can't always get epicardial. But even when we can, coronary arteries are in the way, and epicardial fat is in the way. And so there is a need of reaching these mid-myocardial VTs and even some of the epicardial VTs with deeper ablation than radiofrequency can currently do. So just like UW, OHSU is part of the International VT Ablation Consortium. Melissa and I contribute to this with our cases, and the group is combined at 22 centers around the world, and the group is combined thousands of cases. And non-ischemics are a pain point, right? Here's the group's combined data on recurrence, VT recurrence, and then combine the red bar, and combined VT death or heart transplant at 2 years, it's almost 50-50. So even at experienced high volume centers, these are challenges. So getting back to our taxonomy, so I set out to basically take a lot of the solid tumor thermal ablation technologies and to build them onto a catheter with the goal of achieving deeper lesions to reach these. So here is a catheter that my lab has developed over the years. So this is a 12 French outer diameter nylon catheter housing. We source this from raw materials, and we build it in-house in our fabrication lab. The ultrasound is actually fairly straightforward. It's a single element, 6.5 megahertz PZT crystal. It's air back to allow all the energy to progress forward. It's internally irrigated to cool the catheter. Many of radiofrequency catheters are also irrigated. And it's passed through a steerable sheath. So while we are ultrasound engineers in my lab, what we are not are catheter engineers. And so our catheter itself is not steerable, but we use steerable sheaths to get it where it needs to go. In my postdoc work, I set out to demonstrate its ability to make deep lesions in a dose-dependent manner. We were able to show that here at the highest ultrasound dose, we had achieved nearly transmural lesions, ablating top to bottom. And here's a typical radiofrequency lesion, which is about 5 millimeters deep. Our ultrasound lesions achieved 12 millimeter myocardial depth. So when I came to OHSU, I set out to do this in a more dedicated manner. So the first thing we did is to really try to optimize the acoustics, right? We based our initial prototype during my postdoc on catheters we knew worked for the prostate and other solid tumors. But as I built my lab and we built our ultrasound testing facility, part of my lab, first thing we did is to acoustically simulate using computational modeling, and then build and test multiple different frequencies of the catheter. And we confirmed that, and luckily we had been operating at the right frequency. So we tested frequencies between 5 and 8 megahertz, ultimately confirming the 6.5 does achieve the deepest lesions. We shifted from an epicardial to an endocardial approach. Much easier, much more clinically relevant, and frankly, much more easy to proliferate it if and when this becomes clinically viable product. Femoral venous approach was taken to the right ventricle. Our catheter and steerable sheath would get placed on the right ventricular septum using both intracardiac echo guidance and fluoroscopy. We also had some transthoracic echo guidance on some of these studies as well. This is our pilot study. We since have much more large animal data, but the initial study was on 12 swine, making 8 sonications for a minute each on the RV septum. And we made these sonications, I should say, spaced apart in order to be able to identify each lesion separately. By design, we sacrificed 4 of these animals immediately to see acute lesion formation and survived 8 of them for 30 days. Interestingly, despite ablating in the RV septum and quite basally, we didn't have any instances of AV block, which we'd anticipated possibly having. And I'll explain why that may have been and why that may be an advantage. We had no ventricular septal defects, despite making very deep lesions, no pericardial effusions. We did have 1 sudden death 2 weeks into the survival period. Other than having septal lesions, thermal lesions in its interventricular septum, that swine was otherwise autopsy negative. So I have to say this does raise a concern for proarrhythmia, either setting up the nidus for VT by putting these lesions, spaced apart about 1 centimeter, or maybe late AV block. We're now putting implantable loop recorders into our swine presently so that we can detect the mode of demise if we have this complication in the future. All swine underwent transthoracic echo pre-ablation, post-ablation, and at 30 days. A subset also underwent MRI at those endpoints in our animal MRI facility. So as I said, I set out to assess this for VTs. We purposely spaced these lesions apart so we could assess them individually. And the ablation here is being performed from the right ventricle aimed in towards the left ventricle. And impressively, we're able to make our lesions quite deep in the septum. The lesion depth was 11 to 12 millimeters from the RV septum in towards the LV, similar to what I'd shown in the epicardial work in my postdoc. Lesion volume is robust initially, much larger than radiofrequency. And we're sparing, to a variable extent, the first few millimeters of the RV subendocardium. And to the point of AV block as a potential complication, we know that the His-Purkinje system, the right bundle, the left bundle branch block in particular, are subendocardial structures. So I at least hypothesize, and one of my goals in the next phase of this project is to confirm that we are able to avoid AV block by purposefully ablating over the right bundle and the bundle of His and skipping over it. So we'll talk about how future work is aimed to prove that hypothesis. So here's how the lesions evolve over 30 days. So again, the ablations performed in the direction of the arrow from RV to LV. And you can see acutely the lesions are deposited quite deep in the mid-ventricle. Look at 30 days. The lesions evolved to form nice, dense, collagenous, fibrotic lesions with a necrotic core. And the septum really remodels around these impressively large lesions. And these lesions were, again, not made on purpose to coalesce. They were made to be spaced apart. Histology showed nothing surprising, confirming in trichrome that the lesions are distant from the RV subendocardium and deep. And H&E showed a typical coagulative necrosis of thermal ablation with a mild amount of inflammatory infiltrate. MRI confirmed the same thing. So these are late gadolinium enhancement sequences from our cardiac MRI. You can see the LV and short axis here. Normal myocardium should appear black on these sequences. Dysfunctional or scarred myocardium should show up as white. And so the arrow is a direction that ablation was performed. And here's an acute lesion, nearly transmural LGE in the interventricular septum. Here are chronic lesions. So 2 here spaced apart as by design in this short axis cut. And again, the lesion thinned around it. The engineer in my lab, David, was charged with performing an image processing algorithm, and developing rather. So he wrote code to do automated image processing of the lesion. What our goal is to make these lesions from the RV and push them as deep as we can, both to span as much as transmural as they can be, but also to see how far we could get them towards the LV. So we used spline analysis to basically automate what the mid septum was, and then quantitate how much of our lesion ended up on which side. So immediately post-ablation, the lesions were 56% transmural. At 30 days, as the septum shrunk around them, that transmurality increased to 82%. The lesion didn't get bigger, the septum just got shrunk. And we'll get to how that's been a new phase of our research. As far as how much of the lesion was pushed from the RV to the LV side of the mid-septum, about a third, and that remained the same at 30 days. So that's something we want to improve upon. So I've alluded to this with a few of the last last few slides that I've shown you, but OHSU is a fairly big HCM center. And, you think of your research ideas often when you're on the wards or in clinic. And I was fortunate to be asked to be the electrophysiologist for our HCM group shortly after arriving. So I attend an HCM clinic, and right around when my HCM volume was really starting to ramp up is when I was making these observations in the lab of the septal reduction. So I sat down with our HCM team and we said, started to wonder if this could be, in addition to VT, a potential therapy for septal reduction in hypertrophic cardiomyopathy. So I've just put up a figure that I've already put up for you, a representative image of how the lesions, but more importantly, the septum remodels over 30 days to really thin out. So we took these same swine where the studies had been done for VT, and we went back and we quantitated the septal thickness. And immediately post-ablation, the septum are 16 millimeters thick. There's, those in the audience are familiar with normal human septal wall thickness. 16 is pretty thick. These are healthy swine. These are not HCM swine. But the 16 millimeter is due to a combination of a little bit of acute edema from ablation, but also the scientists in the audience know when you fix tissue, these are all formalin fixed, proteins cross-link, and then myocardium thickens a little bit. So I'm not insinuating that these pigs had 16 millimeter septum, but even on gross path, the septum shrunk from 16 millimeters to 10.6 thickness at the level where the lesions were made. And these swine grow impressively over 30 days. So just to account for that, we normalized the septal thickness to posterior wall thickness where we didn't make any ablation lesions. And the ratio of septal thickness went from 1.06 to 64%. So about approximately 35% reduction in septal thickness when normalized. I feel like the echo clips rarely project well on Zoom, but I hope you can see these short axes. This is pre-ablation, fairly normal short axis of the left ventricle. Immediately post-ablation, we get impressive stunning of the interventricular septum and a little bit of acute edema from the ablation. At 30 days, ejection fraction is overall preserved. There's no change. But there's a mild decrease in wall motion of the interventricular septum. Septal thickness by echo is reduced both in diastole and systole. We also looked at strain. So we looked at septal, circumferential, and radial strain, focusing more on the basal anterior and the basal inferior segments. And we compared all of those to the other 4 segments where no ablation was performed. And pre-ablation, as you see, these images don't project well on Zoom either, but the yellow and red curves are the strain curves for those 2 segments where ablation was performed. So pre-ablation, they're fairly close to the dotted line. And then immediately post-ablation, a marked reduction in those 2 segments that remains reduced at 30 days. I've not included the quantitation of this data, but it's all, that work's been published. T1 sequences in MRI further confirmed our echo and gross pathology findings of septal reduction, as shown here. And then I've already presented to you the LGE findings from a VT mindset of making transmural lesions. But here again, appreciated on the LGE sequences that the lesions shrink over time, but so does the septum. So while I continue to work on VT, I'm passionate now about the second application of, frankly, an identical catheter for the purposes of septal reduction therapy that we can do from a femoral venous right ventricular approach that will have fewer risk of stroke and systemic thromboembolus and arterial access. And I'd like to shift to talking about HCM as a clinical indication, just to keep this talk bouncing back and forth between science and clinical work. So like us, UW is a very impressive hypertrophic cardiomyopathy center. Dr. Owens and I had a wonderful chat yesterday about the limitations of existing therapies, but let me sort of discuss that with the rest of you. So HCM, for those not familiar with it, is the most common genetic cardiomyopathy characterized by increased contractility and increased myocardial thickness that is most often asymmetrically affecting the interventricular septum. That asymmetric thickness of the basal septum leads to left ventricular outflow tract obstruction. So the septum obstructs egress of the heart through the aortic valve. That can result in chest pain, shortness of breath, hospitalizations, arrhythmias, and sudden death. The two existing therapies for this have significant limitations. Septal myectomy is a sternotomy-based surgery in which that thick segment is surgically excised by surgeons. It has a very high periprocedural risk. The periprocedural mortality of this, especially at low volume centers, is exceedingly high, 5% all comers, up to 15% at low volume centers. That's not the case at UW and OHSU, where we're high volume centers, but we'll get to some of that data. But even in experienced hands, the risk of AV block and pacemaker, because the left bundle cannot be visualized by the surgeon, is 10%. Alcohol septal ablation is a less invasive version of performing this. It's arterial access, cannulating the left main coronary artery, hoping that the patient has a septal perforator, the left anterior descending, that can be cannulated with a balloon that's then inflated, and ethanol is injected distal to that. Challenges there are you similarly cannot control the risk of AV block because the septal perforator certainly may perfuse the His-Purkinje system. There's data on proarrhythmia of this, both of Brady and tachyarrhythmias. Luckily, most of these patients have defibrillators. And lastly, it's limited by the availability of septal perforators. You just have to hope the patient has the right branch. Some patients don't have one at all that perfuses the most hypertrophic segment. And some patients require repeat procedures. The best data on complication rates in the US shows an impressive dependence on hospital volume. So I always lament that these investigators chose multiple shades of green, but let me take you through it. So they broke down US hospitals by tertiles of volume. So the darkest green is all hospitals in the US, and the y-axis are incidence of the various complications. So this top graph is septal myectomy. All comers, periprocedural mortality in the first 30 days is 5% for HCM patients. At the lowest tertile of volume, it's over 15%. Even at the highest tertile, mortality is in 3 to 4% range, which is impressive. Now, at OHSU, we're well under 1% for this, and I'm very sure UW is as well. Pacemaker rates seem not to be as volume dependent. Typically, if you're doing a better job and excising more of the hypertrophied segment to be more effective, you're increasing your chances of excising the left bundle as well. And stroke rates are fairly low, 1 to 2%, but still not zero. Alcohol septal ablation shows, by virtue of being less invasive, lower overall mortality, but even in the lowest tertile of institutions, there's a 2% periprocedural mortality, and that's often due to underappreciated AV block, either early or late, or underappreciated proarrhythmic risk of making new lesions in the septum for pro-tachyarrhythmia. And pacemaker rates are quite high, even at high volume centers. So my next phase of my scientific career is to continue the VT work, but also optimize my device and my lab's device for HCM. And how are we going to do that? So these are largely regurgitation of the aims of my R01 proposal, but we're experimenting with larger transducers. We're a femoral venous approach, so there's not a huge pressure to stay at 12 French catheter size. We're experimenting with larger transducers that will be able to make deeper lesions. As you saw, our catheter is side-facing. It's not circumferential. So we're developing methods of confirming that our transducer is actually touching the tissue and oriented such that the acoustic field is deposited within it. We're incorporating our catheter into existing electroanatomic mapping systems that we all use in the EP lab. We want to confirm this proof of principle that we can ablate over the His-Purkinje system, which is subendocardial, and deposit our lesion beyond it and not cause AV block. We want to see how our lesions perform in and around myocardial scar. This pertains to both VT and HCM. All the data I showed you were in healthy swine. And so I've had a chronic MI model, chronic infarct model in my lab for several years that we use for various industry collaborations, but I'm interested in seeing how my catheter's lesions perform around scar. And then lastly, we're working on developing a large animal model of obstructive HCM. That's a huge shortcoming in our field, in the HCM field. There is one swine model of non-obstructive HCM, but there are no animal models of obstructive HCM. The largest animal that can get clinical obstructive HCM is the Maine Coon cat. I don't know if anyone owns a Maine Coon cat or has seen one, but they're very big. They're probably halfway between the size of a domesticated cat and a tiger. And we've had veterinarians that we've worked with to take care of Maine Coon cats. I often include a picture of a Maine Coon cat in these slides, and have asked us for help, frankly. Unfortunately, even from a right IJ approach, we haven't been able to get our catheter to the RV septum in that size of large animal. So we'd like to develop a swine or other truly large animal model of obstructive HCM, and we have some ideas of doing that. So let's talk about how my lab is assessing contact. So as I mentioned, this is a CAD diagram of our side-facing transducer. It's very challenging, I've learned, to both perform therapy and image with the same ultrasound transducer, and we can get into why. But we've found a way of doing that. And basically, it's not that different than diagnostic echo, but it does require a lot of post-processing and filtering to filter out artifacts. And we basically send a pulse and receive it, much like diagnostic echo does, similar to the A mode that I started showing you. But in order to do it with the transducer that can also provide therapy, we have to perform filtering via Hilbert transformation, which makes it challenging. And what's our readout? So our readout is this blue curve that is the filtered and transformed waveform of the received echo pulse. And so if we're not directly orthogonal to the cardiac tissue, then we will not receive that pulse. And thus the transformation shows this blue curve staying right at its baseline. As we are confirming we're making contact, this blue curve rises. And so we're using this method to improve real-time visualization. So this is fairly early, but what I'm going to show here is simultaneous transthoracic echo. So this is imaging. Here's the right ventricle. Here's the left ventricle of a swine. And this is performed while I'm at the bedside, physically clockwise torquing the catheter from the RV lumen to push onto the interventricular septum. I hope you can appreciate that. Here's fluoroscopy at the exact same time. So clockwise torque to bring the catheter to the septum. And then keep your eyes on the blue curve that I showed you earlier. So, it's still a work in progress, but we're defining the cutoffs above which it must rise that will predict adequate contact and adequate lesion formation. We've incorporated electron-atomic mapping into our catheter. So the non-EPs in the audience won't recognize this, but this is a cardo map of the right ventricle. This is the tricuspid valve. This is the right ventricular outflow tract. These orange dots are the His-Purkinje. These are the His signals, and this is the right bundle signal. So we map the right ventricle as we would do in a clinical case. We tag the His-Purkinje system, and then we can visualize at least the tip of our catheter. So these two silver bars correspond to the electrodes that we've now incorporated onto our catheter, either end of the transducer, and we know the lesion will be performed in between them. And we're going to use this to prove our principle of ablating over the His-Purkinje system. This is an example of one of our fairly modest LAD infarct swine. So you can see the pale area. This is a TTC stained gross pathology of a swine heart. LAD is coursing here. And this is a relatively small infarct. We're building larger ones. Of the apex of the LV is a pale area that doesn't uptake TTC stain. So we use this model for several other projects, but we're using it to see how our lesions perform in and around scar. So here you can see a fairly small mid-septal scar, more so on the LV side than the RV side. And you can see, at least in this example, our lesions have no problem creating lesions in border zones of scar, which is something that radio frequency does not do very well. All right, so with my remaining time, and I'll leave some time with questions, let's talk about commercialization within academia and how we can take this work forward. I mentioned a lot of the investigative work that I want to do with myocardial fibrosis and amyloidosis, and certainly with interested colleagues here, stem cell engraftment. But in parallel with those new applications, I do want my work to reach humans. And UW has an amazing track record with commercialization and one of the best tech transfer offices in the country. But the first step I've learned the hard way through VT in determining and commercializing your work is showing that the market is there for it and that there's an unmet clinical need. And when I was only in the VT space, every time I would meet with the large strategic companies, the Boston Scientifics, the J&Js, Biosense Webster's, their response to me would be, oh, it only works for VT. Come back to me when it works for AFib. And here's why. So here's market surveillance data looking at volumes of VT ablation and AFib ablation, and then projections going forward. So AFib outpaces VT ablation by about a 5-to-1 margin. And that's, forecasted to continue. However, I will say one silver lining is projections of VT ablation growth are 9.1% growth per year, and that of AFib is only 7.3. So that's one silver lining we hang our hat on. But I think we have to be honest that for VT only, this is a small market, especially because I have to be honest, this catheter will only really be needed for the subset of VTs where radio frequency is inadequate. But what about HCM? So it's currently projected there are 1.5 million HCM patients in the US. 2/3 of those, so about 1 million, have clinically relevant LV outflow tract obstruction. And the current volume of septal reduction therapies is low, 1,200 patients per year. 500 of those get myectomies, 700 are alcohol septal ablations, and many of these are repeat alcohol septal ablations, so they're not unique patients. And so we've got a big unmet need here. I'm not here to tell you that we're gonna treat all 1 million patients, but there's a huge gap between 1,200 per year and 1 million 1 million who have the disease. So I estimate a combined clinical need of about 10,000 patients per year benefiting from a less invasive version of septal reduction therapy that may not cause AV block. And then a 10% market share of the VT would be about 15,000 per year, which is 25,000 per year who would benefit. I have to be honest about our competition. So in the HCM space, myectomy and alcohol septal ablation we've discussed at length. Selective myosin inhibitors, so mavacamten and aficamten following it, are expected to significantly improve at least symptoms of this disease. Some hypothesize that they may reduce the need for septal reduction therapy. On patients' behalf, I'm hopeful that that's the case. On my selfish scientific behalf, I'm hopeful that that's not the case. And Dr. Owens and I had a very fruitful discussion yesterday about how this will pan out. But I'm eager to see that, and I'd be lying if I'd say I wasn't concerned that this is a competitor of us as a septal reduction therapy. In the VT space, I showed you the unsatisfactory depth of radio frequency. Pulse field ablation, the EPs in the audience know this is the next big thing, certainly for AFib ablation. My lab does a fair bit of pulse field ablation work that I didn't discuss today. It can ablate the ventricle. The lesions are not that deep. They're not much deeper than radio frequency. I can tell you that much. VT radiation, so the same radiation that oncology therapy that's used for solid tumors has been applied for VT patients who are poor candidates for ablation. We do this at OHSU with some success, but the outcomes seem not to be as reproducible as the first few centers who have championed this, and there's no reimbursement pathway worked out. And then finally, there are needle catheters where the needle gets literally stuck into the myocardium and RF is delivered from the needle. Those do generate very large lesions, but as you can imagine, handling that from the groin and deploying a needle into a moving heart is quite unwieldy and challenging. So in parallel with continuing my science that I've discussed, I've learned a lot, partially through my experience at Vibrato, partially through our tech transfer about the regulatory pathways here. The first step we have taken, and I'm eager to do it at a future institution, is we've made our animal lab GLP compliant. So every experiment that comes out of our animal lab, the data will be submittable to future FDA applications. So that's a check. And that took the help of a few consultants and some hard work of my lab manager. My lab, it doesn't have a clean room, right? We have a very talented catheter engineer, ultrasound engineer, but we're not an FDA level ISO certified quality systems fabrication company. And so we need help with that, and we have pathways to do that. The next step, once we have these two done, is to get an investigational device exemption from the FDA. We've had some early conversations with them. And then to move into first-in-human studies via the FDA's early feasibility pathway. And so this is our path forward. So the first step is to do the quality systems engineering with an SBIR award that we've currently submitted. The next step is to submit the Q submission. And then the final step, which comes back into academia, is to pull off the first-in-human study, which I'm eager to do. So who's going to run with it? You know, a lot of my mentees ask me about how they can get their work to commercialize. How can they get it into patients? And some are interested in starting a company. And I ask them, well, are you interested enough to quit your day job, right? Because ultimately somebody has to run with this. And I ask myself that all the time, am I going to quit my job and start a company? And my answer is no. I love clinical electrophysiology. I love my patients, and that's not in my immediate future. Can we partner with a strategic company like a Medtronic, or should we partner with a healthcare incubator? And this is the path that we have taken, this number 3, certainly for our immediate future. We've partnered with a healthcare incubator, Caridia, that has a great track record of partnering with academic partners. And in parallel with the academic partners R01 work, writing joint SBIR grants. And they've recently partnered up with Deerfield Venture Fund to form Deerfield Catalyst. So these are my current partners in taking this forward. Wonderful. So this will leave some time for questions. But in summary, I'd like to summarize that therapeutic ultrasound may offer a novel therapy in its non-thermal pulsed form for peripheral arterial disease and critical limb ischemia by way of causing acute vasodilation and chronic angiogenesis mediated by pannexin and direct ATP release. It may offer a new therapy for VT by achieving deeper lesions, and it may offer a new septal reduction therapy option for HCM patients by achieving deep septal LV lesions from the RV side while sparing the subendocardium, possibly reducing risk of AV block. I'd like to thank my funding agencies, NIH, American Society of Echo, Siemens and Biosense, who supported this work with hardware contributions, some philanthropists. Here is my small and humble lab. David Giraud is a UW alum, former member of CIMU. Jim is our research sonographer. Yen is our lab manager. And in the interest of lifelong mentorship, thank my mentors and then a few collaborators here. So thank you. I'd like to open up for questions.
Thank you, Babak. That was outstanding. And a great example how translational science can be brought to the clinical world and back.
Awesome. Do you mind if I start with a question?
Go ahead.
So I think it's a great example of being in clinic and then finding an application for the technology, your interaction with the HCM lab. My question is sort of a practical one. You definitely showed a lot of shrinkage around the area of damage and the scar. Is it just the fact that you're causing an injury and necrosis, or is there something specific about the ultrasound-induced cell death that causes more shrinkage than other types of ablation?
Yeah, great question, Dr. McClellan. I think it's not exclusive to ultrasound. There have been people trying to do this with radio frequency, actually. There are a few manuscripts out there. Ultrasound thermal injury histologically is not that different than radio frequency or a microwave. However, topographically, it is in that the lesion is deposited in the midseptum. So while the actual tissue on a histological scale is a thermal necrosis, coagulative lesion, my hypothesis is the fact that it's deposited in the midseptum and not on the RV side of the septum, and hopefully as we build larger catheters, push to the LV side of the septum, is responsible for the shrinkage. The RF data in the centers that have tried using radio frequency, the limitation there is that the lesions made on the LV side, so it's arterial access, approximately 40 to 60 RF applications have to be made in a small area, which markedly increases stroke risk. And the septum doesn't shrink that much, I suspect, because the lesions are subendocardial and not in the mid-septum. So it's more of a geographic characteristic of ultrasound, not a thermal or direct tissue effect unique characteristic.
And you said you'd gone to Maine Coon cats as your model. Do the pig transgenic models, do they not recapitulate the septal hypertrophy?
Correct. With the pig transgenic model out of Iowa that was sort of also used by myocardia is a non-obstructive model, unfortunately. It develops concentric hypertrophy. It does develop a little bit of heart failure. It does develop fibrosis by MRI and gross pathology, but there's nothing asymmetric about it, and it doesn't have any clinically relevant LV outflow tract obstruction. Our approaches to generate an obstructive HCM model are going to involve an injection, a combination injection of a biopolymer, more to come on that, combined with a growth factor combination, direct injection of the interventricular septum from a catheter-based approach. I'm not sure that I have the expertise to generate a genetic swine model that is obstructive when all of myocardia tried. And the Seidmans tried too, I think, to that point.
All right, maybe a couple more questions. We're a little bit over time. In the Q&A, Dr. Kirkpatrick asks, have you used contrast perfusion to assess HCM lesions during intervention and then follow?
Great question. Yeah, I'm mentored by one of the contrast ultrasound perfusion zealots. The challenge in a pig model is that the same microbubbles used that I showed in the for the PAD work in the mouse studies and then the human sickle cell studies. Pigs get impressive complement-mediated immunologic responses to them, and they sometimes just go into anaphylaxis. So I will say it's a great question, and it is one of the sub-aims of my future proposals, but you have to pre-medicate them for an impressive amount of time with steroids and high doses of NSAIDs. So I haven't done that yet. I may do it in the future, but ultimately this immunologic response may keep us from being able to do that in the swine model. If we change to other animals, we'll do that. Right now, I didn't talk about this, but we are looking at novel non-microbubble-based echo modalities at assessing lesion formation. And we have a partnership with Siemens where they're allowing us to make some software changes on our research system in the animal lab to do different types of diagnostic echo. I can't say too much more about that because it's a mutual NDA, but it won't involve microbubbles and the immunologic response.
Okay, maybe we'll make Dr. Matula's question the last one. I know we're running over time. Does vasodilation occur along the entire ultrasound path from transducer to focus, or is it a threshold effect occurring near or at the focus?
Great question, Tom. I have to say that answer to that is not definitely worked out. The presence of microbubbles lowers the threshold for vasodilation. So if you have microbubbles in the lumen, you can use relatively low mechanical indexes, even some within the diagnostic range to promote vasodilation. In the absence of microbubbles, you have to raise your acoustic energy and your mechanical index to generate vasodilation so that there is a threshold response. So I think it really just depends on the shape of your field and when you get to that threshold. Interestingly, though, since ATP is freely diffusible, you do get some vasodilation along the vessel lumen outside, usually downstream arterially, right? Outside of your acoustic field, as that ATP you've released freely diffuses downstream. So that may be huge in the PAD population where our therapy is on their calf, but their ulcers are in their foot, right? We're not putting the ultrasound over the ulcers for sterility reasons and infection reasons. So there is some downstream flow of at least the ATP. I don't know about the pannexin effect.
Thank you very much, Babak, and thanks everyone for attending. Other questions, please forward them to me, and I will make sure they get to Babak. And I can share his contact information with you.
Yeah,
Thanks
please
again,
do.
and have a
I'll
great-
type an answer to these two remaining questions as well, since I have a few minutes before my next meeting.
Great. Thank you, Babak.
Thank you.